maternity piece of this review course. How the day is going to go is I'm Dr. Suplee. I will be presenting the morning information which will include maternity and women's health issues. This afternoon, Professor Gardner will come in and talk to you about the normal newborn and also the high-risk newborn. So for any of the newborn type questions, I'd appreciate it if you save them to this afternoon for Professor Gardner. What we're going to start with is basically the antepartum period, go into the interpartum period, and then into the postpartum period, and finish with women's health issues. Now, women's health issues do cover and go through all those periods of time, but it's just how I'm going to separate them out today to present them. With regards to the antepartum period, the first thing I want to go over a little bit is just the female reproductive system, A and P. Again, in your book on page 536, you're going to see an anatomical diagram of the external structures. On page 537 are the internal structures. Basically, I know you have had these before several times, so I'm not going to go in depth with them. But what I would encourage you to do is just review them, because as I talk about physiologic changes in pregnancy, some of these anatomical structures will so-called be moved around. So again, I would just ask you to review those for yourself. With regards to the pelvis, you will find that the pelvis and breasts are described as well. So again, I would encourage you to just kind of read about that anatomy. The next thing in your book is the menstrual cycle. What you're going to find is that there are charts on page 539. I just want to go through some of the information on these charts for you. Basically, the thing to remember about the menstrual cycle is that there are three types of systems involved. The first one is obviously the system that we're talking about with the anterior pituitary hormones, the FSH and LH, and how they relate to the cycle. You will notice that the FSH and LH are released from the anterior pituitary early in the cycle. They elevate about mid-cycle, and then they decrease after the ovulation period. What you will also see is that estrogen and progesterone come into play as other hormones that are released. Estrogen basically has a double peak, with progesterone peaking after ovulation. The ovarian cycle basically can be divided into two phases. The follicular phase is the early phase. This is the development of the primary follicle up until the time of ovulation, when the ovum is released, and then the luteal phase, which goes from the release of the egg, the absorption of the corpus luteum, into the latent phase of the cycle. The last one is the menstrual phase, and that's divided into the proliferatory phase, which is the beginning of the cycle. And this is really when the lining is really building up to get ready for pregnancy. After ovulation, you're going to see that the secretory phase comes into play, and then the ischemic phase. So the cycle is very complex with regards to hormones, what happens to the uterus, and what also happens to the follicle if the person gets pregnant versus if the person doesn't get pregnant. So again, I would encourage you to review those cycles as you go along. What we're going to go into now is dealing with fetal development. We're going to talk a little bit about the process of gamete formation, fertilization, and implantation. Again, remember that the woman produces one mature ovum. The male produces about 200 to 600 million sperm per ejaculate. Fertilization of the egg or conception usually takes place in the outer third of the tube. And again, remember, it's usually one sperm penetrating the one egg, and that union is known as the zygote. The zygote forms cells and continue to replicate themselves, and this is known as cleavage. Eventually, this becomes a morula, and it becomes a blastocyst, and it's the blastocyst that implants into the endometrium about on days 6 to 10. Chorionic villi develop and extend into the endometrium, and the chorionic villi helps form the placenta and also secretes HCG. And again, with regards to HCG, we're going to know that that's one of the main indicators when we do pregnancy testing. The area of endometrium that holds onto the blastocyst becomes known as the decidua basalis, and the cells continue to divide and mature throughout the rest of the process. So again, you go from gamete formation to fertilization to implantation. With regards to stages, we have the pre-embryonic, the embryonic, and the fetal stages, which I'm going to talk about. The pre-embryonic stage occurs between days 1 to 14. So again, you're talking about once there has been a union between sperm and egg. Fertilization takes place again in the outer 1/3. I've already clarified that. The blastocyst embeds, implantation occurs, and once again, this is a very crucial period with regards to the person either knowing they're pregnant or not knowing they're pregnant. A majority of the women don't know they're pregnant while this is occurring, because obviously it's occurring after ovulation, and the woman would not have missed a period as of yet. The embryonic stage is significant in that it is the most critical time for organ development. So again, you have the embryonic disc differentiating into germ layers. You have the ectoderm, endoderm, and mesoderm, and there's just some examples of what develops from those germ layers. This usually occurs between days 15 and 8 weeks. So again, it's the most critical time for organ development. And then you have the fetal period from weeks 9 to term. Development of all systems continue. In this we talk about viability with regards to 22 weeks from the last menstrual period, or greater than 500 grams with the developing embryo. The structures of pregnancy include the fetal membranes and the amniotic fluid. The fetal membranes basically consist of two membranes, the chorion and the amnion, the chorion being the outer layer and the amnion being the inner layer. The amniotic fluid basically increases in the amount until term. And you also find that there are disorders, so to speak, of decreased amniotic fluid known as oligohydramnios and increased amniotic fluid known as polyhydramnios. And both of those types of disorders, so to speak, have issues with them. So again, I would encourage you to review those issues. The amniotic fluid is constantly produced. There is no such thing as a dry birth. The amniotic fluid is continuously produced throughout the time of pregnancy. The functions include temperature control. It cushions the fetus, allows for freedom of movement, and the fetus secretes through excretion and also swallows the fluid continuously. Continued on the structures of pregnancy is the umbilical cord, which includes two arteries and one vein. The arteries carrying blood from the fetus, the vein carrying oxygenated blood to the fetus, and then Wharton's jelly is the connective tissue that surrounds the two vessels. So again, it's a protective mechanism. The placenta acts as a function as respiration, nutrition, excretion, and storage, and also produces hormones such as HCG, estrogen, progesterone, and HPL, which all play major roles with regards to the continued pregnancy. Again, remember with HCG, it can be detected in maternal serum between days 8 and 10 post-conception. However, most commercial urine kits will pick it up right before the woman should have gotten her period, about day 14. But some of the kits actually will pick it up before the missed period. Progesterone will maintain the endometrium, estrogen will stimulate uterine growth, and the HPL, or human placental lactogen, will stimulate maternal metabolism to actually supply needed nutrients to that fetal growth. The next slide deals with fetal circulation. What you're going to find with fetal circulation that is most significant is that the arteries carry deoxygenated blood and the veins carry oxygenated blood primarily in the system. There are shunts involved. The foramen ovale does shunt blood between the right and left atrium. It does close at birth. The ductus arteriosus allows for shunting of blood away from the lungs and into the aorta, and it does constrict at birth. And then the ductus venosus is the last shunt, allows for partial shunting away from the liver into the intraovena cava, and this also closes at birth. Significantly with the circulation is that the heart can be audible between 10 and 12 weeks. The heart itself starts to beat about 4 weeks, and it can be visualized via transvaginal ultrasound about 6 weeks. The next thing we're going to go into is the maternal physiologic changes. So again, I'm on page 542 of your book. What we're going to start with is the reproductive system, which is what we're going to start with. The first one on there is ovaries. Obviously, ovulation ceases, so the woman doesn't continue to ovulate through pregnancy. With regards to the vagina, you're going to notice an increase in vascularity, and this is also known as Chadwick's sign, an increase in thickness, an increase in discharge, and it's slightly more acidic. There is a discrepancy in your textbook. It says it's more alkaline, but it's really more acidic. What you are also going to find with regards to the cervix is that the cervix softens a little bit, and it's also known as Goodell's sign. And there's an increase in mucus production, which is normal. Okay, the increase in mucus production is normal, and actually that's where there is an increase with regards to that plug being formed, known as the mucus plug. The uterus does change in size and shape, obviously, as the fetus grows. There's increase in vascularity. There is also contractions, and the early contractions are known as Braxton Hicks contractions. These contractions are necessary for the uterus to stretch and grow. So again, they're not abnormal to have. We will be talking about preterm labor a little bit later in the presentation. However, Braxton Hicks do start very early. There's also a softening of the lower uterine segment known as Hager's sign. The breasts, you're going to notice that women will complain of tenderness of the breast and increased size. The nipples and areola are also enlarged, and they can express milk as early as 16 weeks. Again, this early milk is known as colostrum. The cardiovascular system, you will see major changes in the cardiovascular system. These changes include blood pressure changes. You're going to see a slight decrease in the second trimester, and then the blood pressure should return to the patient's normal blood pressure in the third trimester. What's also going to happen is the heart rate will increase slightly, and there's also a major increase in blood volume and cardiac output. There's also a slight systolic murmur that you may hear during pregnancy. And again, it's just a murmur that is basically benign for these women. And pulmonary, you're going to see an increase in vascularity as well. Nasal mucosa will actually become edematous. Women complain of feeling stuffiness all the time. The diaphragm does increase, and the thoracic circumference increases. And there's an increase in maternal oxygenation requirement. The next system includes the renal system. The renal blood flow does increase, and the glomerular filtration rate increases. So as you can see, there's more of an ability of the woman to have to go to the bathroom more often. With regards to the integumentary system or skin, there is the formation of striae, which are stretch marks. Not every woman gets stretch marks. Basically, it has a genetic component. For years, there was an impression that if you use certain types of creams, these stretch marks will go away, but unfortunately it really is more genetic. So it's something that we can't necessarily control. There is an increase in pigmentation. What you will see is the development of the linea nigra, which appears around the 3rd month. This is the darkening of the skin between the symphysis pubis and the fundal height. So again, it's a dark line. Melasma is also called cloasma. It's the mask of pregnancy you will see with some women. It doesn't happen in all women, but you'll see them referred to as a raccoon mask. So again, there's just like a darkening around the eyes and around the nose. And the last one up there would be the darkening of the areolar and the perineum that occurs with pregnancy. The musculoskeletal system, you're going to see an increase in lumbar lordosis. And this is basically the woman trying to get a better balance of their body with regards to the increased weight. So they tend to kind of push the weight of the child forward, actually curving their lumbar area. And they also have an increase in mobility of pelvic joints, which accounts for the maternal shuffle, so to speak, that you'll hear about, because the joints loosen up. So again, they tend to waddle a little bit as they get further along in pregnancy. Neurologic, there's a few changes. With regards to the GI system, what you will find is gum hypertrophy, an increase in saliva. Again, many women may not want to swallow the saliva, so they tend to try to get rid of the saliva. It also can be that there is an increase in a feeling of nauseousness with the saliva as well. There's a decrease in lower esophageal sphincter pressure. Nausea, vomiting occurs usually between 4 and 14 weeks. And this occurs in up to about 75% of women, so it is very common. Some women do develop a condition called hyperemesis gravidarum that is in your book that's discussed, which is a more significant problem with not only nausea but vomiting and keeping any type of food or fluid down. There's also a decreased motility and tone, more so related to progesterone, and an increase in water absorption. So what happens with pregnant women, because of the decreased motility and tone and the increase in water absorption, they tend to have constipation. The endocrine, placental hormones obviously play a role in the endocrine system with regards to estrogen and progesterone. You will see that the pituitary has a decrease in FSH and LH. The thyroid, there's a slight increase in activity, and also the pancreas, there is a higher demand for an increased production of insulin, and we'll talk about that further when I talk about diabetes. What I'd like to get into now is basically the determination and classification of pregnancy. This is on page 545 of your book. The first thing that we usually talk about with pregnancy is the gravida, and the gravida is the number of times a person has been pregnant, regardless of whether they carry that baby to term or not. The para is the number of pregnancies that have reached viability, and viability usually goes between 20 and 22 weeks. So again, if the baby dies, let's say at 25 weeks, it has still passed viability, so it counts as a para. There is an acronym called TPAL, sorry about that, that kind of categorizes the para a little bit further into term, preterm, abortion, and living. So what you will find is, for example, a G4 is this person has been pregnant 4 times. Her para is a 2, which means she's delivered 2 full-term infants. She's had no preterm infants. She's had 1 abortion, and she has 2 current living children, and that refers back to these full-time paras. Now again, we have an extra gravida here because she's currently pregnant. Okay, so that's where that extra gravida comes in. When we talk about determination, it is based on physical and hormonal changes. So you will see presumptive signs such as amenorrhea. So presumptive signs are usually the woman saying, wow, I think I might be pregnant. So those are presumptive, and there is a list of those in your book. An example of probable would be Chadwick's sign, maybe on a vaginal exam with a speculum exam. The healthcare provider does notice that there is a bluish tint, bluish color, and lo and behold, it's a probable sign. And the last one is a positive sign. An example of that would be actually hearing the fetal heart rate. So again, I would just review those further in your book. When we talk about preconceptual care, what you're going to find is that many women are now planning their pregnancies. So they do go to healthcare providers to see if there's anything they can do to become healthier while they're pregnant. So you're going to see that we're going to try to identify risk factors, the effects of pregnancy on existing medical conditions. Does this woman present with any medical conditions that we have to control a little bit better before she gets pregnant? Any genetic concerns? Again, does she have to be concerned with early genetic testing, which we will talk about? Lab data stasis. Again, is this a person who may be a diabetic that we need to get a hemoglobin A1C on, or we need to get some blood sugar values and get those blood sugar values under control first? Nutritional counseling. Is this someone who may be severely underweight or overweight that they may run into problems because of their weight with pregnancy, that we can give them some counseling? Social and psychosocial issues. Again, there are many issues that women have to consider prior to becoming pregnant and early in pregnancy. What is their menstrual history like? Is this a woman that may actually have difficulty getting pregnant based on the fact that she's had varied menstrual type histories along the road? And then the importance of early and continued prenatal care. We always have to foster that atmosphere that once a person does get pregnant, it's very significant for her to come to prenatal care. Research has shown that we do have better outcomes if we have good prenatal care. So what we're going to go into now is basically the prenatal care over the time of pregnancy. The first one, again, is the goal of healthy mom, healthy infant. And we always talk about that goal as being important. Diagnosis, again, is usually made by many women through using an over-the-counter urine kit. Like I said before, it detects pregnancies about 10 to 14 days after ovulation. It does have a positive and false positive value, so they're not always exact. Obviously, blood HCG is the more exact type of test. Nagel's rule is on page 543 of your book. When you're figuring out a pregnancy or estimated date of confinement, or EDC, we basically use the rule of thumb that you minus 3 months plus 7 days and add a year. This is not an exact science, so again, this can be off by a couple of days based on the fact that not every month is consistent. You have 28 days in one month, you have 31 days in another. So it's given the woman a rough estimate of when her pregnancy or estimated date of confinement is. With regards to a risk assessment, we always do some type of risk assessment. Many of the institutions and healthcare providers will use very generalized forms to get at information that may actually heighten them to the woman's risk of certain conditions in pregnancy. A complete history is performed, as well as a complete physical exam, including a pelvic at this point in time. Vital signs and weight will be monitored throughout pregnancy. Lab work will include initial lab work, as well as screening lab work during some time frames. For example, between 24 and 28 weeks, they're going to get diabetic screening tests done. Evaluation of the fetal development will take place throughout the prenatal care, and I'm also addressing psychosocial concerns. And it is very common for a woman who finds out that she is pregnant to become ambivalent about it. As much as it's a joyful time in some women's lives, it may not be as joyful as planned in some others. So there is some ambivalence that goes along with pregnancy, and that's normal. You will find the other roles include identifying himself as a role of a mother and also establishing a relationship with the fetus. So that happens during the prenatal care period. So the importance of prenatal care and subsequent visits really comes into play. Women are encouraged to go see their provider, and again, it can be a midwife, an obstetrician, some see perinatologists, some see family practice physicians, but they usually are encouraged to see a healthcare provider that are going to care for their pregnancy once a month up until 28 weeks. From 28 weeks to 36 weeks, they're usually going twice a month, and then after 36 weeks, they're usually going once a week. So that's basically the traditional schedule. With regards to nutrition, you're going to find that we do encourage about a 25 to 35 pound weight gain, and this includes about 2 to 3 pounds in the first trimester, and then in the second and third trimester, you're talking just shy of a pound a week. Exercise and sleep are both vital. What you will find with exercise is that women are encouraged to continue with their exercise patterns and obviously are encouraged to get sleep. It can become a little more challenging as the uterus grows and as the fetus grows to get comfortable with sleep. Sexual activity, there are no restrictions unless, of course, for comfort for the woman or if she has any types of complications of pregnancy. Medications, women are encouraged to avoid all medications while they are pregnant unless specifically identified by the healthcare provider for a condition. The women are obviously encouraged to take vitamins and folic acid. Again, with folic acid, all women are encouraged to take 0.4 milligrams a day. If they are at risk, for example, if they have had a child with a neural tube defect, for example, they're encouraged to take 4 milligrams a day if they are going to try to get pregnant again to decrease the risk. Folic acid, we do know, does make a difference, so we continue to encourage women to take folic acid even when they are not pregnant. With regards to behaviors, we encourage to stop smoking, decrease alcohol consumption, and stop as much as possible, and also to decrease and stop the use of illicit drugs. Continuing with patient education, the fetal growth and development, it's really important to discuss this with the patient and what the expectations are and what the baby is doing at what point of development. Common discomforts are listed for you on page 550 of your book with interventions. And again, common discomforts really relate back to the physiologic changes of pregnancy that occur. So again, these are normal changes, they are normal comforts, but unfortunately for women, they are still discomforts. And again, the word is used loosely because for some women, these are really troublesome things they have to deal with. It's very important to explain to a pregnant person what to expect. For example, the physical changes, but also what they may expect psychosocially and also environmentally. They should be taught about the warning signs of pregnancy, also safety promotion, for example, wearing safety belts and seat belts, fetal activity and testing if they are required, and then also preparing for parenting should also take place. Childbirth education, the methods of childbirth can be found on page 548 of your book. Again, there are different methods, and women do have the choice of which method they would like to follow, including, again, the Reed, Lamaze, or Bradley, or other method includes, for example, hypnosis or yoga. Breastfeeding information should be given, interpartum options, what options does the woman have for her interpartum care, pain management for labor and delivery, what are the signs of labor, infant safety, postpartum and infant care, and contraception. So as you can see, there's always something to teach a prenatal patient regardless of the trimester she is in. Now I know this list is very lengthy, and obviously you wouldn't want to give all that information on the first day. So again, it kind of gets spread out throughout the pregnancy. We also encourage patients to read textbooks, for example, what to expect when you're expecting, for example, is a book that many of the providers are handing out now to their clients. And again, it's just one option. There are also many other books that people can find in local bookstores. So what we're going to do now is get into a little bit of the screening and diagnostic tests. And these include genetic and fetal. Again, this is on page 548 of your book. Are there any questions so far? We're going to run through the screening and diagnostic tests, and once again, it does not mean that every woman has to have these tests, first of all, okay? Many of them are screens, and once you screen in positive, then you may be offered a diagnostic. So again, screening does not mean a diagnostic, and you need to be clear with that. The first one is fetal nuchal translucency. and first trimester screen. These are fairly new with regards to screening in the first trimester. For many years we only screened in the second trimester, so these are fairly new. The first trimester screen considers age of the mother, CG, PAP-A, which is a protein, and also nuchal translucency, which is a measurement of the fetal neck on ultrasound. So again, it's kind of like not the fetal neck itself, but actually a portion of where there may be some fluid behind that nape of the neck. And again, anything greater than 3 millimeters is considered abnormal. So what they do with the first trimester screen is basically look at these parameters, and it will detect about 91% of Down syndrome cases. It also gives you some information on trisomy 18. So it doesn't give you information on spina bifida or neural tube defects. It's really giving you information on genetic information. Women are choosing to have these early tests done to give them more information, but again, it is only a screen. So a woman can screen in positive and not have a child with Downs or trisomy. So it's important to remember, because screening is actually going to capture a larger population than the person who actually will have it. The chorionic villi sampling, or CVS. CVS has been around for quite some time. What you will find with the CVS is that it detects chromosomal abnormalities by karyotyping. It's usually performed between like 12 and 13 weeks. It used to be performed earlier, but they don't suggest to do that anymore. They really encourage between 10 and 13 weeks. Cultures are back in about a week. It does give information again on any type of chromosomal abnormalities. The next one is the maternal serum alpha fetal protein. Again, a screening test. Important to know that. And the maternal serum alpha fetal protein is basically a fetal globulin synthesized by the fetal liver. So it's excreted by the fetus into the amniotic fluid, and a small portion crosses the placenta, so it can be measured in maternal serum. So again, this does consist of a maternal blood draw. Basically, it's measured between 15 to 20 weeks of pregnancy. You will see some say between 16 to 18 is the most valuable, but again, 15 to 20 is the range. And it detects about 85% of open neural tube defects and about 25% of Down syndrome. So again, it's not the best indicator or screen for Down syndrome. So again, if it's elevated or if it's decreased, that's going to give you more information. The multiple marker screener, or MMS, consists of a measurement of alpha fetal protein, HCG, and unconjugated serum estriol. And this detects about 60% of Down syndrome cases. So with this test, there's a little higher of a predictive value, but once again, it is only a screen. So if a person screens positive for maternal serum alpha fetal protein, or a MMS, they're usually given the option of having a diagnostic test. And the diagnostic test at this point in time would be an amniocentesis, because the multiple marker screen and also the maternal serum alpha fetal protein are usually obtained between 16 and 20 weeks. So they miss their opportunity to have a CVS. So once again, we're looking for, at this point in time, neural tube defects, which really wouldn't be picked up in the chorionic villi sampling. However, genetic tests would be. An ultrasound is another mechanism for identifying some screens and for identifying some diagnostics. You will see transvaginal ultrasounds being used as well as transabdominal. Amniocentesis has been around for quite some time. It is the removal of amniotic fluid between about 15 to 17 weeks, and it does detect chromosome disorders. Also, if you have it done after like the 16th week, it'll also give you information on neural tube defects, because it'll give you an alpha fetal protein marker. Again, this detects about 90% of open neural tube defects. So by no means are these tests 100% foolproof, and that's very important to tell the woman, is that a CVS and amnio, as much as they're diagnostic, they're not 100% diagnostic. The biophysical profile is another test we can offer, and this is later in pregnancy. This is use of the ultrasound to assess fetal well-being. What you're going to find is it's non-invasive. It uses the fetal monitor as well, and includes fetal breathing movements, fetal tone, amniotic fluid volume, and fetal heart rate to actually come up with a score on how that fetus is doing in utero. So again, it's more information to add to the puzzle. The non-stress test and the contraction stress test are two other tests that are used later in pregnancy. Again, they're not being used genetically. They're being used to give you information on the fetus. The non-stress test, what you're looking for is that there's an increase in fetal heart rate to fetal movement. So it's similar to when we exercise, our heart rate goes up. That's what we want to see with the fetus, that the heart rate goes up. It's also non-invasive. The person is put on a fetal monitor, and we track fetal movements. And our goal is that when we see fetal movements, or the patient feels fetal movements, that the heart rate will go up. We look for 2 or more accelerations of 15 beats per minute lasting for 15 seconds over 20 minutes. So again, it's a 15 by 15 window, 15 beats off the baseline, and it lasts 15 seconds. The test is either going to be reactive or non-reactive. A reactive NST is what you want. A non-reactive test basically means that the baby really didn't show us any accelerations, and you then may want to move on to the next test. In some institutions, the next test is a biophysical profile. In other institutions, the next test is a contraction stress test, which we'll talk about next. With regards to the contraction stress test, which is the last one on this slide, you're going to find that it is also a test that we look at the stress to observe fetal tolerance, and the stress that we actually give the patient are contractions. So we give the patient IV Pitocin usually. There are some institutions that use nipple stimulation. However, it's not as easy to control as giving IV Pitocin. What you will look at is to see how the baby reacts to contractions. And this we're looking for late decelerations. So again, it's negative. If there's no late decelerations, it's positive. You will see repetitive late decelerations. If you get a positive contraction stress test, you're going to need to work farther on what you're going to do with the woman. You're not just going to send her home, because basically it's saying that once that baby is experiencing any type of stress, what we see on the monitor, what we visualize, is something that we have to work off of. Okay, the question is that there are an awful lot of screens and diagnostic tests, and how important it is to know what timing those tests are offered. What I'd probably encourage you to do as you're studying for your boards is put them in a timeline, because again, that'll help you have a better understanding of why would I be doing this when. So for example, if you're thinking about fetal nuchal translucency in first trimester screening, fetal nuchal translucency after about 13-14 weeks, it's not going to give you any information anymore. So if you put it in, and I almost kind of did it with this screen, is, your earlier test, your chorionic villi sampling, once again, after 13-14 weeks, can't do it anymore. So put it in some type of timeline for yourself. The maternal serum alpha-fetoprotein multiple marker screener, if you can remember about 15 to 20 weeks on them, kind of put them together. They're just a little bit different of a test. Ultrasound can be done anytime. So again, you have your transvaginal ultrasound that can be done very early. We start following, for example, our infertility clients very early with transvaginal ultrasounds, up until using ultrasound at 42, 43 weeks. Biophysical profile, again, is usually later, non-stress test contraction. So I would kind of put it in a timeline for yourself. And then also, if you could keep track of screening versus diagnostic, because you can't automatically say, well, a person had a positive MMS, that means that that woman has an open neural 2 defect. That's not what it means. It basically means that she's screened in, that she may be a little bit of a higher risk. and then she should be offered a diagnostic. Can the woman decline a diagnostic test? Absolutely. Okay. The good thing about screening, though, with regards to the neural tube defects, ultrasound has become significantly better. So many women are relying on, let's look at the spine on an ultrasound and honing off on getting an amnio. But again, it's a choice. So you will see that some women will use the ultrasound information as well. The next, do you have a question? The next kind of heavy topic we're going to get into is complications of pregnancy. Now, what you're going to find with the complications list is that there are many complications listed in your book through the antepartum and the intrapartum and the postpartum. So what I did was I'm kind of going to talk about these in a general way, and then we're going to talk about the postpartum complications a little bit later when I do the postpartum period. But basically what I want you to get away from this is that if a person is having a hypertensive disorder, for example, it doesn't just automatically go away. So some of these complications will go from antepartum to intrapartum to postpartum. There are many complications listed in your book. I'm obviously not going to cover them all, but we are going to start with some on this list here. And then again, if there's any questions as we move forward, please let me know. The first one we're going to talk about is an incompetent cervical os. This is on page 550 of your book. And what you're going to find with regards to definition is the painless dilation of the cervix. So the woman doesn't necessarily know she's dilating, okay? It's picked up with regards to an exam. So the clinical manifestations would be a history of repeated loss or early dilation. So you would have to wonder about if a woman presents and she's had 3 or 4 multiple very early losses, maybe she has an incompetent cervix. So again, history plays a role. Early dilation would be found on a pelvic exam. The management includes several things. They don't always jump right to a cerclage, but a cerclage is a surgical procedure and it's usually inserted between 10 and 14 weeks. What you will find with a cerclage is that there are certain types, but the majority of people use what we call like a purse string. So here's the uterus here, here's the cervix, and it has started to dilate. A cerclage would basically be a stitch both ways, and it's called a purse string if you think about those old-fashioned purses that you would pull closed. That's basically why they call it that name. So there's actually a stitch put in here to prevent the cervix from dilating. When the person gets closer to term, obviously we're going to need to go in and clip that stitch so she can go on to labor and deliver. Significant information with regards to that stitch is that there is a heightened chance of the woman having some preterm labor, and also there's a chance of nicking the amniotic fluid and infection. So it's not without risk, obviously. It does include a period of bed rest, and also the woman is encouraged not to lift anything heavy. And she's followed with repeat vaginal ultrasound, so they want to see how the stitch is doing and if the cervix is shortening. Education, they are at risk for preterm labor or PPROM, and again it's preterm premature rupture of membranes. So many times the membranes may actually rupture before the woman is going into labor. If at any time the woman does rupture, usually what happens is they go in and remove the stitch because she's at an increased chance of infection as that stitch stays in. Ectopic pregnancy. Ectopic pregnancy is the implantation of the fertilized ovum outside the uterine cavity. It is the most frequent site is the fallopian tubes. What you will find is though there are other sites and they're listed in your book. How the woman presents basically is that they usually will say they missed a period, so they do think they're pregnant. Abdominal tenderness or abdominal pelvic mass, and this can be unilateral or bilateral. Okay? An abnormal vaginal bleeding is also what they present with. What you will find with regards to diagnosis is they look at HCG levels. And normally in pregnancy, the HCG levels double about every 36 to 48 hours. So by about 6.5 weeks, there's usually about a lab value of about 1,000 milliunits per milliliter of HCG. What you're going to find with the ectopic pregnancy is that the lab values are not doubling. Okay, so there may be an HCG that is actually lower. Also, they will find that progesterone normally increases with pregnancy, but in women with an ectopic pregnancy, there's actually a lower progesterone level. So they're looking at HCG levels and progesterone levels with ectopics. And also an ultrasound can help diagnose because the ultrasound can get a pretty good image if there is a baby in utero or not. Management consists of surgical management or medical management. What you will find with surgical management is a salpingectomy or a partial salpingectomy, the removal of the tube. This is usually used if there's a greater than a 4 centimeter mass, so they will be measuring the mass size. If it's less than 4 centimeters, they can try a medical management, which consists of IM methotrexate. Methotrexate causes the pregnancy to terminate, and it interferes with DNA synthesis. These women are followed with repeated HCG levels until they are undetected. And education should include issues with future pregnancy, depending on if they did a partial salpingectomy or a complete salpingectomy, and also emotional support and obviously use of contraception. The next topic is Placenta Previa. This is the implantation of the placenta over the cervical os. There are 3 types: marginal, partial, and total. And the presentation is usually painless vaginal bleeding. However, it can be associated with some uterine contractions, so that's important to know. What you're going to find with the presentation is basically where the placenta is lying. You know, is it totally covering the os? Is it partially covering the os? Or is it basically low lying where it's just covering, just kind of hitting the os? And depending on where that is going to be dependent on the woman's care. If she has a total previa, she's going to need a cesarean section. If she has a low lying or sometimes a partial, they will give her a trial of labor and see how she does. But sometimes she ends up a cesarean section anyway because it's going to be varied on the amount of bleeding if she does it at all. Management, again, varies according to gestational age, fetal condition, amount of bleeding, and the location of the placenta. We do encourage no cervical exams because any cervical exam can actually irritate the cervix and cause the placenta to bleed. Continuous assessment of the maternal and fetal well-being. Monitor labs, blood loss, and uterine activity. C-section versus vaginal delivery will actually be a decision that the healthcare provider will have to make. And obviously education. Many of these women will present with bright red vaginal bleeding, and it may be time that anything has gone wrong. So what you're going to find with that is that you're going to need to get to the point of why is this woman bleeding. So the first thing they usually do is an ultrasound, and this usually does diagnose the placenta previa. It does not mean the woman is going to bleed throughout the rest of her pregnancy. Some women will come in and bleed once and never have another episode, and other women will come in and bleed once and continue to bleed throughout pregnancy. So again, it really is a condition that is monitored for a long time until the patient delivers. Give me a high sign when you're ready for a break, okay? Abruptio placenta, this is the premature separation of the normally implanted placenta. The woman definitely presents with a mirage of symptoms, including uterine tenderness and specific pain. You're going to see in some textbooks that it's called board-like abdomen or rigid abdomen, but the woman usually has some specific pain. High-frequency contractions may be picked up on the monitor. And what I mean by high-frequency contractions is usually you have contractions that have a space in between and really kind of sit on a baseline. With high-frequency contractions, you may see more of contractions like that, where the uterus never really relaxes down to baseline. So again, they're usually frequent and also above the baseline. They're called high-frequency contractions. There may be some vaginal bleeding, old or new. Not every person that presents with an abruption has vaginal bleeding. Possible signs of shock. Again, if this woman is bleeding internally, she may be presenting to you in shock. So again, if I asked you what would be some of the signs of shock you may see, what would they include? I can't hear you either. Anybody? What would the blood pressure be? Decreased blood pressure. What about the pulse? Increased pulse. Respirations? Could be, again, depending on the stage of shock she's in, it may vary, okay? Non-reassuring fetal heart rate tracing or possible fetal demise. Again, if the placenta has completely pulled away from the wall, the fetus is not getting any blood supply. The patient can present with a demise. The other thing is, depending on the amount of blood or the amount of pull away of the abruption, will be dependent on how that fetus is tolerating the blood supply they are getting. So you may see a non-reassuring fetal heart rate tracing, and what you'll probably see is that that fetus is going to be having late decelerations and may actually be having tachycardia before you see bradycardia, because it may be trying to react to try to keep up with the blood supply. The management, again, depends on the degree of abruption, the age, the fetal status, and the progress of labor. So again, your care is going to be dependent on, is this woman coming in with an abruption and she's not even in labor, she's long and closed, she's 33 weeks, versus the woman presents at 40 weeks, she's 5 centimeters, and lo and behold, you see there's some abruption. So the care will vary depending on the presentation. You need to stabilize the mother. Obviously check frequent vital signs. Do an ultrasound, fetal monitoring, monitor blood values, INO, and you may even actually be administering some blood replacement. Delivery options are going to be discussed, and also education to tell this woman what is going on and what to expect. The next complication is hypertensive disorders. What you're going to find with the hypertensive disorders are that there are some categories or types that have been recommended with regards to trying to have a better understanding of the disorders. Preeclampsia, eclampsia, superimposed preeclampsia, chronic hypertension, and gestational hypertension. Basically, what you need to remember is that 6 to 8% of pregnancies are complicated by preeclampsia, which is what we're going to focus on. This is on page 552 of your book. When we talk about preeclampsia, you're going to see that it has been divided into mild preeclampsia and severe preeclampsia, depending on the presentation. Mild preeclampsia, you're going to see an increase in blood pressure and proteinuria. It used to be that they called it a triad of symptoms including edema. We don't utilize that category anymore, so please correct that in your book. It's really based on blood pressure at this point and proteinuria, and also other end organ involvement reactions, so to speak, or lab values that we will see. The woman can have an increased weight gain that you will keep track of, and you can see that women can have edema normally in pregnancy, and that's basically why they took away that third category of edema, because pregnant women can have edema, especially of the lower extremities. Severe preeclampsia has a longer list of kind of pointers. Blood pressure greater than 160/110, proteinuria, which is similar to preeclampsia, but sometimes you see a greater proteinuria. If you're using a dipstick, for example, usually it's a higher level dipstick. Elevated serum creatinine, IUGR or intrauterine growth restriction. Again, if this baby is not getting enough blood, you're going to see that the baby's growth is going to be a little bit off. Cerebral symptoms, these may include things like headache or blurred vision. And the other thing you'll see with, neurological type symptoms is hyperreflexia. So you will be monitoring the patient's reflexes as well. Elevated liver enzymes are pretty classic with preeclampsia because the liver is involved. And thrombocytopenia may be another issue. Oliguria is related to a decrease in glomerular filtration rate, and therefore the patient is going to have oliguria. What you will realize through preeclampsia is that it really does affect every organ. So for example, if you have a decrease in glomerular filtration rate to the kidney, you're going to see proteinuria. You're also going to see an increase in uric acid, which is a very significant test for preeclampsia as well. With regards to the liver, you're going to see a decrease in hepatic blood flow. Therefore, you're going to see an increase in liver enzymes due to damage. You may also see an increase in bilirubin. However, it's a slight increase. And the women can actually rupture their liver. You don't see this very often, but it does carry a very high mortality rate. Women will be asked if they feel any lower upper uterine tenderness with regards to liver involvement. You have to be very specific of where you're asking that woman, do they feel pain? If you say to a woman, do you feel pain in your right upper quadrant, that is much too vague. You need to really pinpoint where that liver is and actually put pressure under the rib cage and say, do you feel any tenderness when I palpate here? This will give you a better idea. If the woman is contracting, she's going to say she has pain in her right upper quadrant, so you have to be more specific. Again, they may complain of blurry vision or scotoma, which is seeing spots. And again, it's related to a decreased blood supply and also retinal arterial spasms. With regards to the uterus, there may be a decrease in uterine blood flow, so therefore you are going to see some intrauterine growth restriction. You may see generalized edema because of shifting fluid from the intravascular to the extravascular space. So again, they may have pitting or non-pitting edema, which you'll have to measure. CNS, like I talked about before, you may see some headache, hyperreflexia, even ankle clonus. With regards to pulmonary, they may complain of feeling short of breath. They can also develop pulmonary edema. This is basically because of colloid osmotic pressure is decreased and therefore allows for fluid to seep into the other spaces. What you'll find with cardiac is that you will have some slight cardiac changes. You may have a decrease in preload. Therefore, you may see even a decrease in CVP readings if you have one in place. So again, to review, blood pressure is an issue. And blood pressure is an issue in that you sometimes see trends of blood pressure versus clear cut. If it's over 1/3, if it's over 30 millimeters of systolic, over 15 diastolic, that criteria is somewhat old. We look for more trending of blood pressure. Because again, you have to remember, if a person's normal blood pressure is 90/60, we don't want to wait wait until it gets to 140/90 to say that the woman has some hypertensive problems. So again, you really have to look at the person. Management depends on several factors, and usually it's mother and fetus dependent. Interventions may include bed rest in the side-lying position. Again, remember, a side-lying position is always going to increase the blood supply to that fetus. Fluid management is going to become critical. You don't want to overload these patients with fluid, and you have to be careful of the oliguria with the output. You want to do continued assessment of lab values. This would include obviously a CBC, a chemistry panel, and also your liver enzymes. You want to assess vital signs frequently, lung sounds because of the chance of pulmonary edema, and reflexes. You want to observe for worsening signs of symptoms. The fetal assessment, the person is going to be on a fetal monitor. You want to monitor not only the fetus but also the contraction pattern, and administer medications. The drug of choice for preeclampsia management is magnesium sulfate, and we'll talk about that in a minute. And antihypertensives are used, but they're usually not used until the blood pressure reaches about 160/105 or 160/110. Delivery is definitely a consideration. This disease process does not automatically go away. This person will still experience or can seize in the postpartum period. So again, it's something that we have to be very careful with delivery, and obviously continued monitoring post-delivery. With regards to mag sulfate administration, the goal is to prevent convulsions, and I think you really need to remember what the goal of this therapy is. Preeclampsia can turn into eclampsia, and eclampsia is when the person actually has a seizure. With regards to what it does, it decreases CNS irritability, it depresses the vasomotor center by acting on the peripheral vascular system, and causes a slight vasodilation effect. So if I'm saying it causes a slight vasodilation effect, what I'm finding is that there is a possible lowering of the blood pressure, but that is not the true goal of why we give this medication. IV administration, we do a 4 to 6 gram load followed by 2 grams an hour. And during this administration, the woman may complain of feeling very hot and warm, almost like having a hot flash. And you usually see that during the load. You want to monitor for signs and symptoms of magnesium sulfate toxicity, which may include what? Not with magnesium toxicity. If you have too much magnesium on board, what might you say? Everybody, yay. Okay, if you have too much magnesium on board, right, you're going to have decreased reflexes. That's okay. You're going to have decreased reflexes because the magnesium is kind of doing its job, okay? So you may see decreased reflexes. What else might you see with toxemia or toxicity, excuse me? Yeah. Hypotonia. Okay, so again, the woman may be almost laying in the bed, not even able to move. So you may see hypotonia. What else might you see? What about respirations? Decreased, okay? Respirations decreased. You also may see some oliguria, okay? So again, if a woman is holding on to magnesium sulfate and she has oliguria, magnesium is excreted through the kidney. So therefore, that magnesium level has a chance to build and build and build. So you have to be very careful watching for magnesium toxicity. Therapeutic mag level is about 4 to 8 milligrams per deciliter. What you will find is the normal mag level in the body is about like 2.6-ish, around there. So it is elevated. We want that elevated lab value to come back because then we know that we're decreasing her possible response for seizures. The antidote is calcium gluconate if you do get into trouble with magnesium toxicity. We're going to take a break now for about 10 minutes, and then we'll pick up with diabetes. Okay, we're going to pick up with diabetes. This is on page 554 of your book. With diabetes, what you're going to find is it's the improper metabolism of glucose. Now, I know you all probably had the review last week. they went into diabetes in depth, I'm sure, so I'm not going to spend a whole lot of time going over what diabetes is. However, what you need to know is what happens with pregnancy if a woman is diabetic, or if she gets diagnosed with gestational diabetes during her pregnancy. So what you will find is that there are different types, type 1 and type 2, which are your standard types. And then you have gestational diabetes, which means the person is diagnosed during her pregnancy. There are certain effects of pregnancy. Early, what we see is because there's a decrease in appetite and possible nausea and vomiting, and there's an increase in glucose utilization as the fetus develops, but there may be a decrease in insulin requirement. Later in pregnancy, you're going to see an increase in insulin requirement and possible hyperglycemia, and then in the postpartum, you're going to see a decrease in insulin requirement again. So it basically increases over the length of the pregnancy and then will decrease into the postpartum period. What's significant about diabetes in pregnancy is basically that it does account for about 2 to 5% of all pregnancies, and 90% of those are related to gestational diabetes. So the majority of people with diabetes in pregnancy really do have gestational diabetes. What we do encourage is screening women between 24 and 28 weeks. And what we usually do is as a first method is a 1-hour GTT, or a 1-hour glucose tolerance test. So again, the woman does not need to fast for this test. And if we see an elevation greater than 140, the woman then goes to a 3-hour test. With regards to the 3-hour GTT, what we look for is 2 abnormal values indicating a positive test. You will see that with the 3-hour GTT, it requires the patient to have a carbohydrate load 3 days before, and they should be NPO after midnight. With the 3-hour test, we want to get a fasting value, and then the woman is going to drink a glucose solution. And then after that, there's going to be blood draws, 1 hour, 2 hour, and 3 hour. There are 2 different schematics with regards to criteria. This is a more conservative criteria, these values. You may see in textbooks still some values of a fasting of 105, and then a 1 hour of 190, a 2 hour of 165, and a 3 hour of 145, and I'll repeat them. A less conservative model is a fasting of 105, 1 hour less than 190, 2 hour less than 165, and 3 hour less than 145. So again, once the woman is classified as a gestational diabetic, she usually is managed by diet first. So they will give her nutritional counseling. They do not automatically start on insulin, but they will try diet management first. The management and education is pretty significant with diabetes in that we have to follow these women very closely. So the goal obviously is euglycemia, or keeping that glucose at a level that is desirable. Desirable fasting glucose is between 60 and 90. The preprandial can be anywhere from 60 to 105, and this is again if we test the blood before the person eats. And then a 1 hour postprandial less than 140 and a 2 hour postprandial less than 120. This is what we would like to happen, and I'll repeat them again. Fasting 60 to 90, preprandial 60 to 105, 1 hour postprandial less than 140, and 2 hour postprandial less than 120. Diet, exercise, and glucose monitoring. The woman is going to be monitoring her glucose levels daily. Fetal surveillance will become important because we have to monitor these fetuses very carefully for growth. Timing of delivery. If a woman is managed well and her glucose levels are under control, obviously she's allowed to carry to term. And the patient education list is extensive. Not only do you have to inform inform her about the diagnosis of the diabetes, blood glucose monitoring, diet and exercise. You need to teach her about signs and symptoms of hypoglycemia and hyperglycemia, but you also have to teach a significant other about those signs as well and what to do for them. When and who to call for emergencies, what to do for emergencies, and support and encouragement. And the diabetic education goes right into the postpartum period. You have to remember that 50% of women with gestational diabetes will go on to develop overt diabetes later in their life. So it really is a significant marker when the woman gets diagnosed with gestational diabetes. HIV and pregnancy, this can be found on page 555 in your book. It's under AIDS and pregnancy. Basically what I want to just touch on is the transmission that can occur with pregnancy. What you find is that it's a vertical transmission, but what we want to do is limit the prolonged rupture of membranes to, again, limit the chance of infection. You may want to consider having an elective cesarean section. This is something that is being offered to patients with positive HIV status. Administer prophylaxis medication in labor. This again is something that is being offered to all women with positive HIV status. They are also followed with medications throughout their pregnancy. And we also encourage limit breastfeeding in this country. The next topic we're going to focus on is preterm labor. Preterm labor accounts for about 12% of deliveries. That's the latest statistic in the United States, which is pretty significant because it is not going down, it's actually going up. For years it was about 10% and now we're up to 12%. What you need to know with preterm labor is that it is labor that occurs between 20 to 37 weeks. I'm sorry, we're on page 570. And what we usually find is that the woman experiences uterine contractions that are in a regular pattern and also cervical change. So I want to just discuss cervical change a little bit again with regards to what we measure. Again, the cervical effacement is the shortening of the cervix, and usually the cervix is very long when a person is not ready to deliver. So it can go from 0 to 100. So we may say the person is 100% effaced, means that that cervix is really nice and shortened, versus 20% effaced, it's still rather long. So again, 0 to 100% is effacement or shortening of the cervix. Dilation is how far open the cervix is, and this is usually measured with the use of your fingers. So again, it's how open the cervix is, goes from 0 centimeters to 10 centimeters. So again, the person may be 1 centimeter, the person may be 10 centimeters and more on the verge of delivery. So again, when we talk about cervical change with preterm labor, is that the cervix is making some change. The person may be effacing and also may be dilating. One of the significant things that I think we as nurses have to do is recognize the signs and symptoms of preterm labor. And you will see a list up here: contractions and cramping, vaginal discharge, thigh pressure, low back pain, GI discomforts. People may perceive the baby as balling up. Some people will say they feel the baby move, when in actuality the baby is, she's having a contraction. So her description of a balling up feeling is usually a contraction. Pelvic pressure, bloody show, shooting pain in the vagina, or just not feeling right, which is very vague. So if a woman says to you when she's pregnant, I just don't feel right, you really have to investigate further to see if she's having any signs and symptoms of preterm labor. There are risk factors for preterm labor. The major risk factors include a prior preterm labor and delivery. Prior preterm labor and delivery is a major risk factor. Multiple gestations are major risk factors. Multiple gestation. And again, I think there's also a lengthy list of other risk factors for regards to age, and also conditions like smoking, uterine anomalies, sexually transmitted diseases or infection does put the woman at risk for preterm labor and delivery. So what becomes your nursing assessment with regards to maternal and fetal needs? And we're going to do that in a case study in 1 minute. With regards to medical management, we get into some tocolytic therapy. And again, it doesn't mean that the woman has to go right to tocolytic therapy depending on what's going on. So again, we may look at hydration if this woman is dehydrated. We also may look at decreasing her activity level, or if she's somebody that stands on her feet all day. And also we may look at ruling out infection, because if infection is also enhancing the risk of preterm labor, we also want to focus on that. What you will see with regards to medical management is there is a lengthy list of tocolytics. And tocolytics are designed in the hope of decreasing uterine contractions. So just to go over some of them, the first one is magnesium sulfate. Now this isn't the first time today that you heard of that drug, so obviously we're using it for 2 very significant complications. What you do need to know is the drug here is not being used to prevent seizures. The drug here is used to relax the uterus. It's being used to relax the uterus. So it does compete for calcium binding sites on the cellular level. So what's going to happen with magnesium sulfate? Basically, the load is still the same, 4 to 6 gram load. The dosage is still about 2 grams an hour. And you will see the same side effects of administering magnesium sulfate that you have to be careful for if the woman was a pre-eclamptic or eclamptic. So again, magnesium toxicity comes into play, and also you have to monitor for side effects of the drugs themselves. Now, with regards to magnesium sulfate, one of the things we haven't really talked about is the assessment of reflexes. Reflexes are going to give you a baseline, so you always want to get the reflexes before you administer magnesium sulfate, whether the person is experiencing preterm labor or pre-eclampsia, eclampsia. You want a baseline to compare it to, because magnesium, again, is going to cause a decrease in reflexes. Once again, the antidote is calcium gluconate. Terbutaline is basically a drug that stimulates beta-adrenergic receptors in the uterus and other organs. It stimulates beta-adrenergic receptors in the uterus and other organs. And terbutaline is similar to a drug called ridodrine. I know ridodrine is discussed in your book, but you really don't see it used as much anymore, so I'm not going to focus on it here. But terbutaline is still being used. You see it being used subcutaneously. Also, it can be administered through a pump. There are side effects that you have to watch for with terbutaline. Many people complain of chest pain and palpitations related to an increase in heart rate. Anxiety usually gets increased, and there is also an increase in maternal glucose. The next drug is nifedipine, and nifedipine is a calcium channel blocker. And again, this is given in a PO dose. One of the side effects of nifedipine is hypotension. And the last drug on here is indomethacin. Indomethacin, which is a prostaglandin inhibitor. Indomethacin. This can be given PO or PR. And the thing that you have to remember with indomethacin is it's used for a limited amount of time. And does anybody know why? Great. The reason that we have to use it for a very short period of time is it can close the ductus arteriosus. And again, that's one of the shunts we talked about that the fetus has. So we have to be very careful with administration of the indomethacin. So usually it's not used after 32 weeks. And they will follow up with ultrasound and fetal echocardiogram to really watch that shunt. The other thing with preterm labor that you will see being administered are steroids. Now, steroids are used to enhance lung maturity, and they assist in the production of surfactant. I'll repeat that. They enhance lung maturity and they increase production of surfactant. Usually we give steroids between 24 and 34 weeks if women are experiencing preterm labor. Drugs that you'll see used include betamethasone and dexamethasone. Betamethasone is one that you'll see more commonly used. It's given IM, and it's given at an interval of 24 hours apart, and then you will see that 2 doses are given. And this does decrease respiratory distress syndrome if the baby is to be born. So let's talk a little bit about a first case study. And again, this is dealing with preterm labor. MG is a 17-year-old G1P0 at 33 weeks gestation. She presents to the OB clinic complaining of cramping. What would your initial assessment include? 33 weeks, primate, cramping. Let's do mom first. Blood pressure, okay? So let's go with vital signs. You want to get a complete set of vital signs. What else? Mother. Yeah. Urine sample. What do you want to get a urine sample for? For protein for what? Okay. Right now we're dealing with probable preterm labor. So you're thinking more, you might get a urine because she may have a urinary tract infection related to signs and symptoms, okay? Anybody else what we might want to do with the mom? Okay, we may want to do a pelvic exam to see if these cramping or contractions are actually causing her to dilate. So we would do a pelvic exam. What else might... Fern test? Why? Okay, so maybe we want to make sure this woman is not ruptured, so we'll do a check for rupture membranes. And again, we can do nitrazine paper. And what happens with nitrazine paper if a person is ruptured? Turns blue, okay? Because of why? Alkaline, good. Again, it's litmus paper, it's going to turn blue. If it's more alkaline, amniotic fluid is more alkaline. Okay, we're going to do a Fern test to see if she's ruptured. So again, we're going to put some mucus on the slide, let it dry and see if we see a ferning pattern. We'll also look for a pool. Is there a pool of fluid in her vagina vault? Okay, so we're going to check her cervix. We're also going to see if she's ruptured. What else can we do while we're in there? Okay, that's another thing. Let's come back to it. While I'm in doing a pelvic, what else do I want to do? What else do you want to get? What are women with preterm labor at risk for? What may lead to preterm labor? Infection. So maybe we want to get some cultures. Okay, vaginal cultures. Let's go to the dehydration piece, okay? She's 33 weeks, she's 17-year-old, and she's cramping. And what you may find is if a woman is very dehydrated, we'd like to hydrate them. We may start with oral fluids and then go to IV fluids. So we will hydrate to see if the hydration and the IV fluid will try to decrease contractions. What else do we have to do with mom? What don't we know yet? Go ahead. Good. We're going to put her in a side-lying position to increase oxygenation to that uterus, get the blood supply going. What else do you want to do? Okay, let's do an assessment of what's been happening with her. You want to ask her what? When the contractions started? Okay, how often are they coming? What do they feel like to her? Okay, how does she describe them? Get the patient to describe them. You as a nurse want to do what with those contractions? Measure them, monitor them, feel them, okay? So again, remember with intensity, the monitor can't give you intensity. Your hands are going to give you intensity with how strong those contractions palpate. The monitor will give you how often she's contracting and how long the contractions are lasting. So again, it will give you that frequency and duration. Good. All right, so we now know that she's cramping, she's contracting. What else don't we know about the mom yet? Yeah. Okay, we don't know what kind of prenatal care she had, so you'd want to review her chart if it was on file, or get an extensive history from her. Because again, you want to see what are her risk factors for preterm labor. Does she have any risk factors right now that you just are aware of just because of that one statement? Age, very good. Again, we do see that there is an increase in risk factors with age being younger, around 17, and again, in adolescence. Okay, on the fetal side, what do we want to know? Fetal heart rate. Let's get that baby on a monitor. Let's see what the baby's doing. Okay, so we're going to include the fetal assessment there as well.